Right, good morning everybody. Welcome to the first board meeting of 2020. We have apologies from Sir Robert Francis, who has court duties this morning, and from Dora Gill, who is overseas on business. We also sadly have an apology from our normal we normally have a representative of one of our networks, but unfortunately she can't be here because of a family issue this morning, so that's a shame. We don't have any declarations of interest other than the usual ones that were notified to me in advance. Is anything anybody needs to declare? Very good. We last met on the 20th of November. The minutes are in front of you for approval. Are they a true and accurate record of what we discussed then? Thank you very much indeed. There are 4 items on our public action log. 2 of them are for today. One is for later in the spring, and one is for February. So the 2 that or the one that is for today is David Nable's review, which we will come on to in a short while, and then associated with that is an update from on our other activity in relation to Morton Hall. Those are the 2 things for today, and then later on we have the action for Professor Glynis Murphy's report, but that will be sometime in the spring when that comes to us. So I hope that covers the action log. Is anything anybody wanted to raise that as a matter arising that's not otherwise on the agenda? Excellent, that's fine. So we move swiftly, if we may, to the National Guardian's update. I'm delighted, Henrietta, that you're here. I was disappointed that your name tag hadn't been updated to Dr. Henrietta Hughes, OBE. Congratulations on that. It was really good to see it in the New Year's Honours list. And I was particularly pleased, not just for you, but because I thought it demonstrated the importance of speaking up and the Speak Up programme, which obviously you represent, if you like. So I thought it was terrific. So without any further ado, can I hand over to you, please?
Well, thank you very much for those kind words, and also for giving me the opportunity to give an update on our progress over the last year. We've now got more trained guardians in a broader range of organisations. So the network is of over 500 guardians on our directory who've all been trained, and a similar number of ambassadors and champions around the country supporting their work. The organisations with guardians include all the NHS trusts and foundation trusts, many of the national bodies, including regulators, but also independent sector bodies, and also an increasing number of primary care organisations as well. And we've recently published our data report where we've shown that there was a 73% increase in the numbers of cases raised to guardians in trusts and foundation trusts, with the majority of those cases including an element of bullying and harassment or patient safety. But what I'm pleased to say is that there's been a reduction in the reporting of cases as anonymous, down from 18% to 12%. And also that 88% of those who gave feedback to guardians said that they would speak up again, which I think is very encouraging. But worryingly, the numbers of cases where detriment has been recorded is still at 5%. And I think this is a real concern, as it was at 5% last year as well. So we're looking to see how organisations can support individuals who say that they've had detriment, and certainly, working with the CQC in terms of strengthening the well-led inspection in this area. Other organisations are keen to submit data to us, and so we've created a portal so that all types of organisations with guardians can submit data, and I think it'll be quite interesting to see what that looks like in the future. As I've previously described to you, the implementation of the guardian role varies, And we've previously found that guardians without ring-fence time to do this important work are less likely to meet our expectations or feel that they meet the needs of their workforce. We will be publishing our next Guardian survey next week, and alongside the 100 Voices report, which really talks about the stories behind the data, and the annual report, these will be laid before Parliament for the first time this year. As I've described to you before, we've found that the perceptions of guardians appears to be correlated with the CQC rating. And in that, what I mean is that the organisations rated outstanding by the CQC, their guardians are much more positive about the speaking up culture and the role of their leaders and managers in fostering that culture. But the acid test is, what do the workforce say? So we've developed a metric called the Freedom to Speak Up Index, and this is from a subset of questions from the NHS staff survey about whether workers feel encouraged, knowledgeable and secure in raising concerns. And what we found is that the trusts who have the highest Freedom to Speak Up Index scores also appear to be rated outstanding or good in well-led and overall. And when we look at the trends over the 3 years, and that's the great advantage of the staff survey, that the same questions get asked every year of every organisation, we found that 180 trusts had an improvement in their Freedom to Speak Up Index score, with 6 percentage point improvement nationally overall. And London Ambulance Service I want to highlight because they were the most improved trust, with an 18 percentage point improvement in their staff survey of these questions in the 3-year period. We've published a report where we've highlighted good practice from the trusts with the highest scores in each type of trust, so that others who are struggling with this can actually learn from that and use those insights to make improvements. But I've been talking a lot about trusts. We're also working with primary care, where we have vanguard organisations who are really at the forefront of this in terms of developing models of freedom to speak up, and that includes general practice, optical, dental and pharmacy, so that we can then start developing some examples of how others can learn from that and implement the role nationally. We've also created a new arrangement for case reviews to enable cases referred to us to be addressed in a number of different ways and to ensure that the voice of workers is heard. To date, we've published 7 case review reports with 95 recommendations. And in the paper that I've put in for the board today, we've just summarised some of our priorities for next year. And these include support for Freedom to Speak Up guardians with more training and guidance, understanding the impact of the Freedom to Speak Up arrangements on the culture, and that includes some of the data that I've described, but also how we can get insights from that data and how we can support others, including regulators, with those insights. To expand our remit more into primary care and also integration by bringing guardians together from different parts of the patient pathway to remove some of those silos that can cause lapses in care for patients. And improving training for everyone across the health sector, with training for workers, for managers and leaders, so that everybody understands the responsibilities. And finally, with the system, as I mentioned already, the well-led inspection, but also the people plan and others, so that we can create a joined-up approach to make speaking up business as usual in health.
Great, thank you, Henrietta. Ted?
Thank you, Henrietta, and I agree with your aim to make freedom to speaking up a business as usual. So I'm very, very pleased to hear the progress you're making. Can I just reiterate some of the things you said about working with us, which I think it has been really very positive. We're very, very pleased to have supported the rollout of the Freedom to Speak Up Guardians, and we're keen to follow up on the work you've done. Your review that highlights the lack of protected time for Freedom to Speak Up Guardians, I think, is important. And we will be looking into that into our well-led framework going forward. Equally, the issue about detriment, which I share your concern that doesn't appear to be getting any less. And you say it's 5% overall, but actually it varies between trusts, does it not? And I think we will be taking that into account more in our well-led inspections going forward. It is really important that people can feel free to speak up about their concerns without fear of detriment. And so we would look very badly on a trust that actually caused any detriment to people speaking up. But equally, I think trusts got to be careful their actions are not perceived to be detrimental, even if that's not their intention. And I think the kind of culture they create that encourages people to speak freely is really very important. And that's one of the things I think we need to look at in our newly developed World Ed framework.
Well, thanks very much, Ted. And as you know, my organisation was set up without powers, and we rely on the powers of our funding bodies and others to ensure that the right actions are taken across the system. One thing I would say is that we're really keen that organisations that report are not penalised for doing so, because we know that other organisations may not even be asking the question. So I think there's something about the nuance of the questions that get asked at inspection and in the pre-inspection request and generally, so that organisations who are really attending to this and are really careful about and may have systems and plans of how they deal with it, don't get penalised for actually reporting it. What we want is for organisations all to have systems in place so that if somebody either has a perception or objective detriment, that their organisation has got a system in place to deal with that.
Thank you. Rosie.
Thank you, and thank you, Henrietta. I was just going to say I'm really delighted to see primary care and integration on your priorities for next year. I think it's fabulous that we're looking at rolling this out in primary care. It's such an important area, and we're looking forward to working with you on that. And particularly around integration, I think so many times things can go wrong in between different providers, in those gaps between providers, and I think the ability for people to raise concerns and speak up about things that aren't going well and supported between all of those organisational boundaries is really important. So I'm delighted to see that. Thank you.
Yeah, thanks very much. And I think the fact that we're both GPs means that we do have a good insight into what can happen when there are organisational boundaries in place. I'm really pleased that some of the cases that we've highlighted in our reports actually talk about speaking up across organisational boundaries, because that's the really hard thing to do. And I really want to, create those connections and those relationships so that people feel really comfortable about doing that.
Mark.
Thank you, Chairman, and Henrietta, thanks very much. Very good report again. Just in terms of the training, it's good to see that you've got an e-learning product that you're wanting to develop. But I did mention last year that engaging with providers to put the freedom to speak up process and guardian role into their management training would be a good step going forward. And I wonder if you have evidence of providers putting that into their own management training.
Yeah, we're seeing examples of that. So, for example, one of the trusts created a program called Hot Potatoes, and that was for the managers, so that when somebody brings something to you, that they've got a plan in place of how to deal with that. But I'm also really pleased that the NHS Leadership Academy, with the new Rosalind Franklin program, has got a module about speaking up. Now, this is for first-time managers, and my input into that was really very much to explain that managers have got a responsibility in listening well, but also knowing how to escalate concerns themselves. So I think we are seeing pockets of really good practice, and it's then in our conferences and events that we then share that good practice between Freedom to Speak Up Guardians, so that they can take that back to their organisation and ensure that their managers are supported as well. We're working with Health Education England on developing this e-learning, because we want this to be something which is completely universal and seen as completely normal to be doing that. But I agree with you that where we're seeing managers really getting upskilled in this, and actually one of the examples was from one of the trusts that had come up very highly in the Freedom to Speak Up Index. So those organisations have got a lot to share with others. I think the main thing I would say is for organisations who are struggling under all sorts of burdens of either regulation or activity, it's actually carving out the time for their managers to be able to understand and learn, but also the time to listen when somebody comes to them. So we can provide all the training in the world, but actually the practicalities of somebody having that time to listen and act correctly as well is a challenge.
Yes, thank you. I mean, you're obviously right in the last point is carving the time out, and that's why I'm saying to embed it into the management processes in the provider's own leadership and management programs. Would start to create that room, I would suggest.
So if Sir Robert was here, he would say, never ask a question you don't know the answer to, but I'm going to ignore the advice. Henrietta, is there anything that you need from CQC that you aren't getting to progress your really important work?
I think the key is that our timetable is sometimes, let's say, runs a little bit faster because we're a smaller organisation. One of the things which I think has been really important is the way that as an organisation CQC listens when we bring information that's come from the front line. And if I give an example of this, it was that in the pre-inspection request there was a request for information about whistleblowing data. And this was causing quite considerable distress to guardians because they were being told, well, you've got your freedom to speak up data, but where's your whistleblowing data? So what we did was we fed that back to Ted and his team, and actions are being taken to change that. So what I would say is, in terms of being a responsive organisation, that's exactly the type of support that we need, so that when we hear things that are impacting on guardians in the front line and on their well-being, that we can ensure that we get those changes made. So that's the type of help that I need, and that's the type of help that I'm getting.
Perfect, good. I'm glad. Thank you, Ted. Well done. But it is so important. I mean, joking apart, it's so important. So that's great. Henrietta, I know you have to go and be in your practice this afternoon. So thank you very much again for the work that you do and for coming here today. And congratulations again on your honour, which is fabulous.
Thank you so much.
Good. So that then moves us on to the independent report on Morton Hall that David Noble has produced for us. David, can I start by thanking you for the huge amount of work that you've done in putting together the report. I know that both you and I had hoped we would have this report in front of the board rather soon, and a combination of, I think, the exhaustive amount of work you were doing probably delayed it by about a month, and then we ran into the pre-election rules ahead of the general election, which causes another 2-month delay. So it's a shame, but we are here today, which is the important thing. So thank you. And your report is really welcome, even though for CQC it makes some pretty uncomfortable reading in many respects. It's clear that although abuse wasn't identified in 2015, we let people down at Morton Hall by not understanding sufficiently the environment was such that abuse could happen. And I think had we understood that better, we would have made sure that the provider had themselves taken action, which hopefully would have prevented the abuse from occurring. So, we absolutely know we need to improve how we regulate mental health, learning disability, and/or autism services, so we can get better at spotting poor care and at using the information that people give us. And we are working hard to improve, and we want to involve the people, families, carers, and other stakeholder organisations to make sure that we get it right. So your report is a really important part of that. David, we all the board have had obviously an opportunity to have read the report in advance of this morning, and will have done so, and we will be making the report available publicly at the end of this meeting. So given that, could I suggest that, without obviously stopping you saying whatever you want to say that we fundamentally concentrate on the recommendations, which I think are the essential next steps for us as a board. So that's probably what we'd like to concentrate on, but may I hand over to you, David, please.
Yes, thank you, Chairman. Yes, I certainly endorse the concerns about the delay. Inevitably, given when I was appointed, a number of the interviews with key people fell during the critical summer holiday months, and that delayed my ability to interview them. Unfortunately, that meant not making the October board, and then after that, of course, despite the report the review in effect having concluded, this is the first opportunity to submit it to you. I think there's little point in me summarising the 7 recommendations. I'm more than happy to take the discussion as it flows. I think the only thing that I would say is that they cover 3 broad areas. The first are essentially general recommendations about processes that I identified during the course of the review that seemed to me to require improvement. And these covered things like the security and availability of notes from inspection and the presence or absence of legal advice concerning the Commission's duty to publish reports. The second area was really about the quality assurance process, and on that, of course, I've also referred to the other review that the Commission has commissioned from Professor Murphy, who will look at it in a much broader view, but just from the material that I saw around the 2015 and 2016 inspections, I had concerns about the way in which the quality assurance process operated and when it operated, quite late in the piece. And the third, interestingly enough, given Dr. Henrietta Hughes's role, was about the whistleblowing process within CQC, and I note that there have been significant improvements since 2015, 2016. And the only other thing that I would emphasise for those who read the report is that it's necessary for them to read the 3 warnings that I issue in Chapter 7 about the recommendations. I don't overestimate or overemphasise, nor do I underemphasise the difficulty that I've had in dealing with an event that happened now, in essence, nearly 5 years ago. And in any organisation, doing that sort of archaeology will always be difficult, and I think that's an important caveat to place. There will always inevitably be limitations on the documentation, even in a highly IT organisation.
Thank you. Colleagues, Ted.
Shall I lead off? Well, David, thank you very much for the report. It's an important report for us. As Peter has already said, we are determined to improve the way we regulate, inspect, and identify poor care and abuse in these closed environments. And I think we are working very hard to do that. Your report and recommendations are going to be really very helpful in that regard. We are going to incorporate them into the work that is already underway. There's extensive work underway, and members of the board will have noted that we have a programme of inspection of hospitals such as Morton Hall that has identified other problems, and 13 of those have now been identified as inadequate since May 2018, and that is tribute to the work that is going on to identify the problems, such as the problems we saw at Morton Hall. And I think your report, your recommendations are helpful in taking that forward, and we are committed to implementing them all in full as part of that work going forward. And we will, of course, build on that when we get the report from Professor Murphy's report in due course, and I think that's going to be very important. Can I just say a few things? I mean, you do pay tribute to the candour, openness and constructive contribution of the staff you spoke to, and can I just pay tribute to them? They worked very hard, and they were as disappointed as this board in the fact that we did miss the abuse of Morton Hall, and they are as determined as this board to make sure that we improve our regulation and get much better at protecting people from this kind of abuse. Also, you emphasised the importance of whistleblowing, and we've just had the session with Henrietta Hughes. I think you cannot underestimate the importance of staff raising concerns about the services they work in to the CQC in us identifying poor care and abuse. And I'd like to thank all the staff, many who've been energised by the publicity coming out of Morton Hall to speak to us, to help us identify the problems in other centres. They are invaluable to us, and I think they don't get enough recognition for the support they give us in the work we do. And finally, you in your report, you highlight the fact that the model of care at Morton Hall was a model of care that causes real concern in itself. It creates an environment where, a closed environment, where poor care and potentially abuse is more likely to occur. And we highlighted this, of course, in the interim report of our thematic review into restraint, seclusion and segregation, which we published last May. And we highlighted the human rights concerns around that model of care. I think it's very important that as we go forward, we remember that the model of care is something fundamentally that needs to be addressed. We are publishing the second phase of our report shortly in the spring, and that is going to be really very important. And I think it is an opportunity which we must not let slip to allow to move forward from this model of care that has been allowed to last too long in the system. And I think that is another important part of what we can contribute in the aftermath of this. So thank you very much.
Thank you, John, and then Kate.
David, thank you very much for the work you've done on this important issue. I think everyone around this table, and indeed in CQC, who watched the Panorama programme and cannot be failed to be horrified, moved and determined to see care for this most vulnerable group of people improve in the future. We have to play our part in giving them the voice they cannot use for themselves. There were clear failings on the part of a number of organisations and professionals interfacing with Morton Hall, it seems to me, and your report has highlighted very clearly our failings, which we must deeply regret and be responsible for. As a non-exec, I want to play my part in helping the organisation improve care for this group of people. And so therefore I have two questions, one for you and one, if I may, for Ian. Do you think, from your interviews and analysis that you've done over the past few months, you feel CQC is in a different place now than it was in 2015?
I think it's just worth reminding everybody. I mean, David will answer the question, but yeah, David was looking very specifically at 2015, 2016. The Professor Murphy report will look at later events.
I understand that,
I just think it's important.
But equally, he's been speaking to people. He will have a sense
sure.
and
But a
an
lot of the people he
impression.
spoke to, people.
And I think it's important for us to get
David
that.
will speak for himself. I just wanted to make that clear. It's quite an important point, I think. David.
Thank you both. And before I answer it, I'd also certainly endorse what Ted Baker said about the candour of the staff that I've spoken to. I would extend it further to the candour of former staff who I also interviewed, and I think that's a very important point for the Commission to understand, that it has committed staff and it also has staff who left at that time or around that time because they found it difficult to operate in that environment. And that relates back to Sir John's point, I think. And I make this point early in the report, that one of the very important elements to bear in mind is the context at the time. And the context at the time was that CQC itself was going through a very fundamental reform. There was a change to the inspection regime. The introduction of that regime into the private or the independent mental health care provision, I think, was rushed and possibly added to the pressures on staff at the time. So, taking on board the chairman's point, what I found in 2015-16 was indeed an organisation that in this element was going through fundamental change that seemed to be improving the processes that were being applied for inspection. As regards this particular hospital and that particular region and that area of care, I think that implementation could have been better done. And I think there are lessons to be learned for any organisation, frankly, that introduces major and radical change to its operating models as to how to do that and how to handle it. And certainly from the people I have spoken to currently, and it's not within my remit, that seems to have being better handled at the moment.
And if I may just ask Ian, so I know there's an internal Morton Hall group, I can't quite remember the name, but really looking at this and presumably the report here. Will there be an opportunity for them to come to the board or the subcommittees to discuss with us where they've got and what actions are being taken?
Yes, I know Kate's going to talk in detail in a moment about the work of that group, but I think my expectation is that we will come back to the board on a regular basis. I think what we want to ensure, though, is that these actions are properly embedded in the work that we are doing, and that means embedding some actions in the transformation programme. It means separate work in some cases, but it is about embedding these things properly into what we do, as opposed to an action plan we just look at in 6 months' time. And I think the combination of David's work plus Professor Murphy's work when that comes, plus the work that is ongoing that Kate's about to describe, I think gives a sense of a significant number of pieces of work, which taken together should significantly improve the way we work, both with people with learning disabilities and autism in these closed environments, but I think more broadly across the organisation. I think there are a number of lessons to learn right across the organisation from sort of some of the insights that David and Professor Murphy will, I'm sure, give us.
So that sounds like it's an introduction for you, Kate, but seriously, the work that you've been leading is really, really important. So can you update us?
So if I could just echo thanks that's been given to you, David, for these recommendations. So just wanted to provide a bit of assurance to the board about how we're going to oversee the governance of this. So as ever, it's critical when we get a report with recommendations, we have a robust, considered response, and then we track that response to ensure it does what it was intended, which is improve outcomes for people. So the reason why I'm speaking to this is I am currently chair of a programme board called Improving Regulation Today, and that programme board oversees changes that we need to make to the way we regulate in the next kind of 12 to 18 months. So relatively short-term changes, noting the longer-term piece of work that's going on about our strategy and future direction. So I chair this programme board that has deputy chief inspectors from across the 3 inspection directorates, as well as colleagues from legal. So Rebecca sits on the board, colleagues from comms and policy and intelligence. We have an overview of a number of important projects, but the discussions we've had is that it's absolutely critical that the recommendations that you've got, David, has a kind of formal home within a governance structure where we receive regular highlight reports and we have the suitable visibility that progress is being made, and that if people are hitting blockers, we have the right level of seniority in the room to kind of overcome those blockers. So we've received your recommendations. We will start working them up into a robust action plan. The board I chair will have oversight of the progress it's making, but I would like to request to the board that we come back in March time with an overview of that action plan and the progress that we've made by then. Some of this we've actioned already, and some of this is partially actioned, and some of this needs to get started. But I'd really like to come back with a kind of robust picture with good consensus from across the organisation about where we are and present that in March, if that's okay, Chair.
Good, thank you. Liz, you wanted to come in.
Yes.
The microphone.
Thank you.
Liz, your microphone.
Thank you very much for the recommendations, which I think we are, really glad to be implementing in full, alongside some other work which people have described. I think the detail in the report is really helpful, as well as the specific recommendations, and I just wanted to pull out an example to give a sense of it and how it links to some of our other work and what it's really important for us to do and to track, as Kate was saying. So you make a recommendation about improving the information that's available to inspectors, and I think our inspectors do have quite a bit of information available to them from safeguarding alerts, from speaking up information, and increasingly, I think, from the voice of people who themselves are using services. And we're very determined to find the best ways of hearing from people themselves, as well as from advocates and from their relatives. And, there's a whole methodology around that. But I think the other thing is that how inspectors use that information is through a lens which is specific to more closed environments where there are risks of toxic cultures and where people need to spot the signs of those particularly toxic cultures. And we did put out some guidance recently that enables inspectors, even if they don't identify actual abuse, they are able to identify those worrying signs, the risk factors for the potential of abuse, and certainly for abusive cultures or cultures that are damaging to people who are living in quite vulnerable situations. And I think that what that does is, so it's about having the right information, but also being able to use that information in a context in which I think we're increasingly using a human rights framework to guide the whole of this work, and that threads through our work on the Mental Health Act, our work on the thematic review on restraint and seclusion and segregation that several people have mentioned, and our response to your recommendations and to, I'm sure, the forthcoming recommendations from Professor Murphy. So I think we've got a lot of work to do, but I think it's about looking at all the powers that we have, and Ted has mentioned that we've actually closed some of those institutions and we've rated them as inadequate. So the full range of our powers, but also picking up on the detail that's in your report and integrating it with the kind of work that's in train to make sure that we really act. So it's something about we accept all the recommendations and we're going to implement them, but we want to implement them at a level that we can be assured really makes that difference to people who are living in vulnerable situations.
I wonder if I could just add a word to that. Certainly, I absolutely agree that the guidance which has come out recently will obviously help in identifying these sort of cultures. I do make the point that both the notification that was available at the time from NHS Improving Lives, and indeed the 2015 report, if one reads it straight as it is, gave those indications then. So my conclusion was that this is not particularly radical or innovative to identify those sort of flags that would come up in these sort of environments. And it's very important that the Commission follows that through. The second, I think, is to say, having conducted the review and interviewed people from inspector level right the way through to senior management level, that any implementation of my recommendations by any groups or boards within CQC would, in my view, benefit from involvement from the front line. I think you need to involve the inspectorate level in implementing these changes so that it's fully understood and appreciated by those who are going to go out into these settings day in, day out. Because I think otherwise there is a risk that this will be being seen to be done to people rather than done with them.
Thank you, David. Is anybody? Chris?
Just want to echo other colleagues. Thanks for your the detail and the in a sense the clarity of the recommendations are quite important. I think there's two important points. One you just touched upon, and one further. It's important in the way we take the recommendations forward that both colleagues internally and also people who've been involved in this work who sit outside the organisation see how we intend to implement these. I think it gives both colleagues internally and others confidence in our work. I reflect on what we would ask an organisation to do in a circumstance where we were issuing a report. We'd expect them to say we accept the recommendations and then to make sure they have an action plan to implement them. And I think this is particularly important for us because this work sits in a wider context. As John's already mentioned, we know there are services, and Ted's mentioned too, there are services that are not providing the right care for people. And it's important that we can take these recommendations forward quickly so that we can go on to the more important job, the equally important job of making sure service users are provided with safe, effective and environments in which to live. So I thank you for the recommendations. I think the candour with which they'll be taken forward is hopefully clear for colleagues to see, and I think it helps us get on to the important question of how we improve services for people who are experiencing those services today.
The parallel with CQC's own inspections is well made, and I'm not generating a request for further work, but the only difference would be, I suspect, that in the CQC type inspection you would then re-inspect afterwards to see that the action plan had been carried out. So I don't know how you'll handle that, but not with me.
I think you can be confident that as a board we will very much be holding ourselves to account to make sure that it is followed through. Ian, do you want to come back?
Yes, I think, and just I guess in that spirit, that this piece of work was initiated by contact from Mr. Barry Stanley Wilkinson. I do want to record publicly our thanks to Mr. Stanley Wilkinson for taking that brave step to come forward with information, as you rightly said, from 5 years ago and raising that issue. I think what that has done is raise some really important points for us, and we've talked about the recommendations. One of the recommendations you do make, of course, is that we write to Mr. Stanley Wilkinson and offer a somewhat belated apology for the way that the internal investigation was handled. I will be doing that this afternoon, along with a copy of your report. And again, just to repeat Peter's assurance that we will be coming back to this board again and again and publicly talking about the work we're doing to make sure that we can improve the service we offer to people in very, very vulnerable circumstances, which ultimately is what this is all about. Thank you.
So I think everybody that's spoken has said that we are accepting all the recommendations, but can we just as a board formally agree that we do accept all those recommendations? I'm not going to repeat everything that's been said, but I think, Kate, you've got a good process for making sure that the recommendations are actioned, and to David's last point, there is oversight of the board that we can see that they've been actioned along with all the other work that is already going on and in due course with whatever comes from Professor Murphy. So, David, can I just thank you once again for the work you've done? I think it's really, really helpful to us to have your very painstaking and thorough review of what went wrong back in 2015, and we will learn from it. So thank you very much.
Thank you.
Good. That takes us in, I think, to the report from you and the executive team, please.
Thanks, Peter. So I'll begin with talking about performance. Although, as you know, this is the intermediate performance conversation. So I will just pick out some key highlights. As we've said on previous occasions, we've been doing a lot of work in registration, although we did say that we were going to bring forward new key performance indicators in registration in the new financial year. I think what we are starting to see is some important improvements in registration, and if members of the board want to talk about that in more detail, very happy to do that in a moment. But I think it is good to see that the continuous improvement work that we're doing is starting to pay some dividends. I think moving on to other points of performance, I think the active work on digital publisher is going on, but I think it's still a challenge for getting reports published quickly, and it's particularly challenging in the hospitals directorate, and I think you'll see on the report that that's still not where we'd like it to be, but it is something we are actively working on. If I look at the financial position, I think our financial position is good. We are projecting a full year surplus at the moment of £1.6 million, which is about 0.7%, and our capital position is also on track, with a forecast of £13.7 million against a full year budget of £15 million. There's a number of things towards year end that we'll need to take into account, and there may be some slight tweaks to inspection schedules in the last couple of months of the financial year, but I think we look like we've got a strong financial performance at this point. I think and I'll just finish off with people and learning. Our HR, in terms of our HR metrics, turnover is currently 10.8%, and that's within our target range of 10 to 12%. And sickness levels remain low at 3.7%. Before I hand over to Ted, I just wanted also just to update the board on our position in relation to our annual pay rise. As the board members will know, we have an annual pay rise which is due on the 1st of September each year. We are pleased to announce that we've arrived at a conclusion, or an agreement rather, with the trades unions, and we're looking to pay our teams a 2% pay rise on salary, 2% on allowances, and also improve the pay for those who are least well paid. And for some colleagues, that means pay rises of up to 6% at the very lowest end of the pay scale. This pay rise is backdated to the 1st of September and will be payable in the February salary. I think this is a really important point, because I think it demonstrates that we are looking to provide the best possible pay and reward proposition for our people. And as we come back in February to talk about the people plan, we'll talk then about our pay and reward, our thinking on pay and reward more formally. But I think it does demonstrate that we are trying to create an environment where colleagues can thrive, and introducing the maximum pay rise that we can within government rules is important. But I think we also need to recognise that the change work that we've been doing has also enabled us to make efficiencies, and that has also enabled us to make investments in technology, Office 365, new phones, all of that kind of stuff, and at the same time keep fees for providers frozen for next year. And that group of things together, I think, is a very positive productivity and efficiency story, which I hope providers will see positive benefit to, and as well as ensuring that the proposition that we offer to our employees is also very strong. I'm going to pause there, Peter, for questions.
Okay, thank you, Ian. Any questions either on what Ian's just been saying or on performance generally? John. Microphone, please.
I have a question about the performance graphs and stuff. Do you want to take those now? And it's for Rosie. That the PMS inspections returns to rating bar chart, which is showing a change from previous, and quite a number of 17 required improvement and inadequates. I'm just wondering, is there a reason that's suddenly gone up? Because traditionally PMS has been very good at that. And secondly, what's the plan to get that back on track?
Okay, so with return to ratings, first thing to say is we're dealing with quite small numbers here. So quite often it's around, as you can see in the chart, it's 13 inspections or 8 return to rating for inadequate.
I don't want to interrupt you, but I accept that. But
Yeah.
collectively, 17 practices is quite a lot of people.
Yeah.
Patients.
So there's internal reasons and external reasons for this. We've had a focus over the last 3 months on this and looking at our scheduling, looking at our information that we've sent out to inspectors about when they need to return and making sure that they're clear on the guidance. There's some information that we're working through around data quality in this area. I think the majority, though, of these practices, it's related to external factors. So particularly with our inadequate practices, quite often there's a negotiation about when we go back into those practices, which involves discussions with our local commissioning colleagues. Sometimes there's reasons why actually it's not appropriate for us to go into the practice at that time. For example, they've just gone through a complete change in infrastructure within the practice. Sometimes there's reasons that we're trying to line up with other inspections that are happening. For example, we have a situation where we've made a decision to delay going back into practices for a month because the acute trust that they're integrated with is being inspected. So we're aligning those inspections to all meet each other. So there's a variety of reasons. It is an absolute focus of us, and we are working with the performance teams to look at this data on a weekly basis. So it's something we are actioning whatever is within our gift to.
Funny enough, I was going to ask a different but related question, which is that it really is important, and I've made this point before, it's really important that where we are missing a KPI, we're really clear about what is happening in those areas where we miss. So in return to ratings, it's really important, and I think you just demonstrated, Rosie, that you have, that we know what is going on, and we haven't just lost them. There is a positive reason why we're doing what we're doing, and an action plan to get back there. Because, as you sort of implied, John, this is actually about the people who are using those services, so it is important. So you've obviously demonstrated that, and perhaps I could just ask now, Ted and Kate, just that sort of assurance that we're all over the reasons why we're not going back when we should have gone back, and there is an understandable reason for that, Ted.
Well, we're within the KPI in hospitals, and I think a lot of work goes into making the schedule effective to make sure we get back to services. There are lots of complex factors, and so there are always some issues that will delay an inspection for good reasons, waiting for an action plan or waiting for other events to take place. So the team is very focused on delivering the inspections on time, and I think they planned their inspection program a long time ahead. One of the things we want to do, building into the new year and our plans going forward, is to actually build more flexibility into the system. Because while that is very good at delivering these KPIs in terms of timetable return to rating, it means we're less flexible to respond to events as they occur.
So with regard to adults, so far in this financial year, we're almost up to 10,000 completed inspections. So just Rosie talked about scale, I suppose just wanted to start off by acknowledging that. We take a risk-based approach as to how we prioritise our inspection efforts. So we are almost 100% for our returning to inadequate services. We're way up into the 90s for our requires improvement. So we are absolutely focusing on risk in our judgments. We've talked before at board about kind of regional variation, so I've got particular challenges around capacity within the southeast that we're taking measures about, but actually because of that regional variation it's slightly bringing down our overall performance. But again, similar to Ted's, we're within KPI, but I'm absolutely confident in the processes with which my staff are making risk-based judgments about how we're prioritising the services we're re-inspecting.
I realise from your answer, Ted, that I didn't actually frame my question as I meant to, but no, it's fine. What I meant to say was that if you have a KPI of say 95%, you need to be worried about the 5% that you may be within KPI, but you need to be confident you know what's happening with the other 5%. You answered the question that you did. So
well, in which case we do. I mean, we have a focus on all of them, including the ones that we haven't got within the KPI. But having said that, as I said earlier on, I think there is an issue that we need to face up to, and that is if we have a very rigid KPI, it stops that flexibility in our inspection programme. And I think we need a bit more flexibility in the inspection programme to respond to events because things change.
Yeah, and I wasn't asking for either Kate or Rosie to come back, and you answered the question that I meant to ask rather than the one I actually did. So thank you for that. Ian, did you want to?
I think just very briefly, I think one of the things we have invested in this year is upgraded performance management systems, so the ability now to drill into regional and team level performance and look at these things in some detail. And I think all three chief inspectors alluded to that. So I think the way we manage these things is much more sophisticated than it ever was, and it is down to individual circumstances which are looked at.
Right, Ted. Oh, sorry, Mark. Beg your pardon.
Thank you, Chairman. Just wondered if I could ask a question about the finance report that Ian referred to. I mean, clearly this looks very positive compared to the first half of the year where it didn't look quite so good. So it reflects a lot of hard work to get us to where we are. I just wondered a question to Chris, whether finishing the finance year in line with our forecast this year, whether how is that impacting on our work for next year?
Thanks, Mark. I think the hard work we've done in the summer and autumn to get the financial position where we are now means we don't have a significant challenge going into next year. We have the usual cycle of looking at our business plan, our budget, and how that adds up and how that compares across the organisation, but our rate of spend is in a good place to land us into 2021. So earlier in the year, we had issues and we've addressed them, but as things stand, I think we're in a healthy position.
Yeah, thank you.
Anything else on performance before we move on? Right, Ted.
Thank you. In my report, there's more detail about the work we're doing about closed environments. We touched on that already under the independent report feedback, so I won't go into detail about that. Just highlight one thing there that we didn't touch on before, and that is that we have, since the last board meeting, published a well-led review of Signet's major mental health and social care provider. And that's an important point, I think, because well-led reviews of large corporate organisations, I think, are going to become a greater feature going forward. And it's important that we apply the same standards of governance to those organisations as we would to our large NHS trusts. And so I think that's an important milestone for us as an organisation. And we are certainly looking to use that methodology again in future in other circumstances. I've highlighted already the publication in the spring of our the final thematic report about restraint, seclusion and segregation. That's covered again in the paperwork. Just to highlight, next week we have the expert advisory group meeting to decide on the final recommendations in that report. And I'm determined that those recommendations will be strong recommendations that can make a real difference to this group of people going forward. We're also publishing shortly our annual review of the Mental Health Act, and the board will have seen the drafts of that. I think this again is an important statement of our position on the implementation of the Mental Health Act at a time when the government is considering legislation to revise the Mental Health Act. And this is, if you like, a new approach to our report with more focus on human rights and more focus on individual stories of patients who have been detained under the Mental Health Act. So I think it's an important move forward in the way we're explaining what we find in our reviews of the Mental Health Act, the implementation of the Mental Health Act on an annual basis. And finally, the maternity survey is going to be coming out shortly. I can't discuss the results of that before it's published, but having said that, maternity, as the board knows, is one of the areas in acute services where we feel progress has not been made as well as it should have done. We highlighted that in state of care, and this is and this maternity survey where women report their experiences in maternity services is a very important marker of the quality of maternity care. We'll be looking at it very closely. I'll be writing to trusts where we have concerns about the outcome of the survey, asking them to take steps to improve.
Thank you, Ted. John.
Thank you, Ted. My question, in a sense, relates back to something David Noble said, and I know you've alluded to in the past, but many of the providers in closed environments are actually private, like Cigna, are private organisations with NHS patients. But part of our mission is to encourage improvement, but also in an ordinary NHS environment, then organisations would have access to other parts of the service that would assist them in improving. That doesn't exist in the private sector. So places like Morton Hall, we can regulate and inspect, but where is the opportunity and assistance for them to improve within the system?
I think you're right, John, and I think this is an important point. When we find inadequate services in NHS trusts, NHS Improvement provides a support package, special measures to help them improve. And we've found that to be really very positive in driving improvement. It's not infallible, and we still have trusts we're concerned about, but many trusts have improved quite markedly with support from NHS Improvement. In terms of independent healthcare, even if they're looking after NHS patients, which the majority of mental health providers are, there is not that support package in place because they're sitting outside the NHS. And I think it's important that support is found to help these services improve. We can't solve the problem purely by regulation. We can't just close hospitals and solve the problem. So there needs to be support for hospitals to drive improvement. I've spoken to NHS Improvement about this and asked them to develop a support package for these independent health organisations so that when we find inadequate care, we have something, or the system has something to offer those services to help them improve. And I'm very keen that they should develop that process.
Chris.
Just to build on that point, one of the things that's been interesting about some of the organisations we've inspected where we found services aren't adequate is that NHSE have asked neighbouring NHS organisations with good records and reputations to provide some of that the beginnings of that support package, and I think that's quite important. That as you've seen before with trusts that are inadequate have had support packages from other organisations that are better. I think NHS can have an important role to lean into that problem because, as Ted said, quite often they're the commissioner of these services, and to ensure that organisations which are performing well can provide support to organisations, albeit outside the NHS, that aren't.
Come back on that. I mean, I think the other point is that, as I said earlier on, the fundamental issue here that's driving the potential for this poor care is the model of care. And we need to address that. And I think the work we're doing post-Morton Hall, but also the work in the thematic review is going to be very important in driving a better model of care for these patients.
Good, thank you. Malta, I think you're next.
Thank you very much, Peter. In a moment, I'm going to hand over to Chris Day, our Director of Engagement, to talk about some important updates and achievements, I think, from his team and colleagues across the organisation, but 3 things to highlight from me. First of all, as Senior Information Risk Officer for the organisation, I'm pleased to say that there has been no significant things to report over the last month on our information or cyber security risks. Secondly, in line with all other public organisations and government more widely, we have stood down our preparations for potential no-deal exit of the UK from the EU by the end of this month, given that there's now a widely held expectation that the withdrawal agreement will be ratified by the UK and the EU. And going forward, CQC will contribute to the Department of Health and Social Care's negotiations and contributions to the trade negotiations with the EU and other countries. And thirdly, I wanted to highlight that tomorrow we're publishing a report that is the result of our first regulatory sandbox into new technologies in health and social care. A regulatory sandbox is a format and process of collaborating over a very quick amount of time with the developers of new technologies, providers and people using services to identify what good actually looks like in the deployment of new technologies and what gaps might exist in that understanding widely, but also specifically for us as a regulator. And this first sandbox is focused on digital triage tools, particularly in primary care, but also in other areas. And our report that highlights that, including what we believe is a good description of what actually good deployment of digital triage tools looks like, is coming out tomorrow. And we are concluding 2 further sandboxes for the rest of this financial year. One on the use of machine learning in diagnostics, and one on the emergence of new models of care to provide personal assistance and care in people's homes. And they're going to be published by the end of March. And with that, over to Chris.
So, Malta, could I just, before we leave that, I mean, the sandbox was an innovative idea. I think we saw it as a bit of a pilot to see how it was going to work. Given where you've got to so far, is it something that you think has been successful as an approach? And we may need some formal evaluation later on, but I mean, just your immediate sense, is this something that we should be continuing?
So I'd highlight, I think, three immediate things. First of all, I think it's a process that has enabled a conversation with people using services and developers and developers of these technologies and providers that we haven't had in this way before, because it's a very focused, iterative, quick event. And while there is a very clear application process for the developers and services that we work with, it's obviously relevant to anyone deploying these technologies. So there is definitely, I think, a benefit in the type of process, possibly beyond technologies that we can build on. The second one is that it's established a relationship, I think, with a number of organizations that previously we haven't really engaged with. To some extent, the developers of new technology, where I think it's actually very beneficial for us to talk to them very early to understand what is about to happen, but vice versa, it's also really helpful for them to understand what we as the regulator are looking for. And while there's many other regulatory and other bodies involved in the development of new technologies, all the way from the beginning of the research and the evidence, all the way to the deployment of the technologies and services when it becomes relevant to CQC, these conversations can be very helpful, in particular because we can outline what good quality looks like and what we would be expecting when a technology is being deployed in terms of what people using services receive for that. And thirdly, because it has begun to kick off a conversation across the different organizations involved, in this case particularly with MHRA, the devices regulator, and NHSX, the new national body looking at digital service and technology across the NHS and social care, to actually identify some of those gaps and understanding what good looks like. And so we will continue to make our contribution to that, including conversations with NHSX and their emerging work around artificial intelligence in particular.
Thanks, Ian. I think you wanted to.
I think just to build on that, I think what this does do is it publicly acknowledges our willingness to have a conversation with providers around new and novel models of service delivery. I was with a provider on Monday, and they were very positive about the pre-engagement work and conversations they'd had with us, which meant they were able to, when they came to us to register a service, they ended up being able to register that quickly and easily, and they weren't wasting time building a service which was then unregisterable. And I think this is another really good example of this. These are interesting and novel technologies, and what we want to do is make sure that people build them and develop them in the right way, rather than build something which they think is registerable and then find that we say no because there's some quirk to it that says it's unsafe in some way. So I think this is a really positive piece of work, but I think it's part of a broader attitude, if you will, that the Commission has around being open to, if you like, pre-application advice, which I think is very important for people to know.
And I think you made an important point, Malta, that whilst this probably mainly will be about use of technology, it may not be. It could be some other innovative provision of care model. So I think it's to your point, Ian, I think signalling that we really want these discussions. We obviously want to see innovation. We want to see people be able to improve, but it's got to be in a way that we're able to be satisfied it's safe and we can register it. So I think it's great. Well done, and well done for the initiative. I think it's really good. Sorry, Chris, you've been sitting waiting patiently.
That's absolutely fine. So just a few other things to bring the board up to speed with. The first is the launch of our podcast series. So through the conversation we had with both public groups, other stakeholders and providers, it was clear that there was a need for a forum where we could continue conversations that might be about the launch of particular products or initiatives. So the podcast series is our first exploits into trying to do that, to try and take issues that we have. We may have a news day on, but to have a longer conversation to drive change, to think about changing attitudes or behaviours on a particular topic. I'm delighted to say that we've just launched the second of the podcast series. We talked about the first four in the board report. We've got so far 2,500 subscribers who've streamed the first two podcasts. Just to give you a sense of where that sits. The nearest comparison, I guess, would be NHS England's regular series. They get between 200 and 1,200 downloads or streams per month. So it isn't a competition, but that's just to give a sense of where we are in that work. I think this is an important channel alongside some of the other channels that we'll have for engaging with people, not just in face-to-face meetings, but outside that. And I think it will hopefully build not only as a way of us engaging on topics that we think are important, but also listening to the feedback and listening to what's said on those podcasts where we bring people in from outside so they can help us in our thinking around what we do and particularly around the new strategy. The next area was around the launch, and Kirsty mentioned it earlier, the launch of the Give Feedback on Care service. So we've sort of beta launched it, which means basically which is now live on the site. We intend to do a sort of formal launch with stakeholder colleagues at the end of this month. We've also put together a launch particularly around learning disabilities. We've been trialling a number of what we call spikes, areas where we want to really engage with people who may not use this service more directly. So we've been working with organisations that work with people with learning disabilities to try and encourage them to give us their feedback on the care that they receive. And the first week since the service has gone formally live, we've seen a 10% increase in the amount of feedback we've received, which is good, though I think we can get better as we formally launch the service. Interestingly, we've got a better uptake from people searching for a service and then giving us direct feedback. And I think that's really important because that was one of the vehicles, one of the measures of success for this, for how easily is it for people to search for a service, see the service they want to talk about, and then offer us feedback. So we've seen a significant improvement in that. I want to monitor the launch of the service formally, and then come back to board on a quarterly basis to give a sense of how that feedback is working. Just to go back to the point we talked about earlier, getting feedback from people who use services and their families is a vital part of how we understand the quality of service, and making this service accessible and easy to use, and making sure people can get to the end of the process easily, as well as making the information available in the right format for inspectors, was a key and important task as part of this work. We talked about it internally in a meeting last week. I think what was really pleasing for me is the way in which colleagues from intelligence, colleagues from digital, and colleagues from the inspection directorates worked together to make this a good service. So it was a really cross-organisation collaboration to help deliver this service. The last thing I wanted to do is talk about the contract award for Experts by Experience. As colleagues know, Experts by Experience has been part of how we regulate services for a number of years. I'm delighted to say that we've made an award for the new contract to Choice Support. Some of the things that are important to me, obviously, we look at organisations both on a quality and cost basis, and choice support, we're the best supplier on both aspects. It also gives us the ability to harmonise the reward package for experts by experience up to the level that choice support currently offer, and to make sure we get consistency in the quality of experts that are used on inspection and elsewhere. And I'd just like to thank colleagues in commercial and finance who've provided the right support for this contract to be put out, and it'll be a phased launch of this contract. So there's conversations now between now and March, with a formal launch at the 1st of April.
Thank you. Chris, any questions or comments? Ted?
Can I just comment about the podcasts, Chris? I haven't heard them all yet, but I mean, I think they're probably stronger if we bring in people from outside the CQC to talk with us, so we can have a conversation. I think conversational podcasts are, if you like, more they draw you in better than just someone speaking to a microphone. I speak as someone who's just spoken to a microphone for this week.
I agree, and I think what we wanted to do, we've talked to colleagues from NHS providers, from ADAS, and from three third sector groups outside the organisation about how they join together. What they all wanted to see was what we were doing. They wanted a couple of examples of it before they would commit. But I'm happy to say that what they've heard from both yours and from the Give Feedback on Care pilot has been positive. So I think we'll get more interaction with colleagues. I think it's just a good opportunity to make sure we've had a conversation outside to say the report. We've got reports coming up like the RSS report, like we talked about the Mental Health Act report today. I think those reports are an ideal opportunity for us to get the voice of all the stakeholders involved in one place.
And indeed, the next one coming out next week features a member of the Sandbox on Digital Triage that we just mentioned, and the think tank Nesta, to talk about their perspective on technology.
Thank you. Mark, and then Ian, and then Liz, I think.
Thank you, Chairman. I also have a question about podcasts, and I have listened to Ted's, and my question comes really about how we are promoting these podcasts, because I only found out about it by reading Kate's blog. So I just wonder what the process is we're making it very public today, but how are we pushing this forward for our providers to listen to this?
Yeah. So the great thing about being a regulator is that providers tend to read the information that we send to them. So we've got a regular communication with providers, which goes out to different groups each month, and they have a strong open and read rate. So that's one of the vehicles for providers that we will use to talk about the information that's in the podcast, and particularly we'll tailor. So, for example, Ted's what was particularly relevant for conversations within NHS services, so we would tailor it to that group. We also ask for colleagues who work in other organisations to support this, and this is sort of a mutual. So NHS providers, NHS England, the King's Fund all have podcast series, and we on social media we actively support each other's podcasts in that space. And I think there's other opportunities as well. So as we go to events and as we go to other engagements like co-production groups where we have the opportunity to engage colleagues, we will make sure that is available. I think it will develop over time as well. I think people will be interested in particular topics. And I think Ted's point about making sure that and Malta's point about making sure that when we talk to the digital community, we'll use their channels and their networks to promote that podcast, because it will have a particular relevance to them.
So, Ian.
Thank you. And just to finish off that point, we've just kicked off a piece of work to look at a new website, new intranet, and again, part of that is looking at web chat, podcasts, and how to embed those a bit more dynamically in the website than is currently the case. I just wanted to come back on the Give Feedback on Care, really, because I think it's a good example of linking a piece of technology investment with our core purpose. I think this meeting has had a recurring theme through it of the importance of feedback and the importance of whistleblowing. What we've done here with Give Feedback on Your Care is we have designed a digital service that actively makes it easy to give feedback on care, But it's not just a simple form. What it does is it steps people through the importance of the information that they're giving us, and why it's important to give us detail, and even talks about things like the positives and negatives of being anonymous in terms of the feedback. So I think the ability to have almost an interactive relationship with people who, understandably in many cases, are perhaps quite nervous about giving feedback. What we're trying to do is build a relationship as part of that process. So I think it links very clearly to our core purpose in the way that Ted describes, of the more feedback we can get, the better job we can do in terms of serving the public. So I can't praise the team enough, and as Chris said, it's multiple teams across the organisation that have brought this together and have really spent a lot of time with the people that are likely to use this service to make sure that it's really focused and as easy to use as possible. And I think the early results are showing a really big uptake in the numbers of people who are using it. And as Chris describes, once we really start to push the button on promoting this, I suspect that's going to go up and up and up in quite a dramatic way.
Liz.
Thanks very much. I wanted to just talk about the focus on learning disabled people in the Declare Your Care. So this seems both very important and very timely, given all the work that we've been discussing earlier about people with disabilities, autistic people. And so I suppose one issue is it would be great to, if there are any patterns in the kinds of feedback that people are giving, that it would be good to be able to feed those into our thinking. If people are commenting on, for example, the quality or availability of community-based support, that kind of issue, or indeed about more institutional provision. And also, it would be good to think about any learning in terms of how we effectively reach people with learning disabilities. And obviously, we've done that. You know, we've done that kind of engagement. But I think it would be good to keep that learning going, because it's really important that that voice comes through to us. The other thing was just experts by experience. So good that the contract's been let. And I think in the fullness of time, it would be great to have a discussion maybe in the Regulatory Governance Committee about kind of how experts by experience, you know, where they're adding the most value, how they're supported and trained, what the dynamics are of how they operate within the teams during inspections and all of that, to make sure that, you know, it's working as well as it can. And I think we'd be really, really keen to have that discussion, but, you know, not until people have got their feet under the desk, so to speak.
No, thank you for that. So in terms of the learning disability spike on give feedback on care, we've already seen some trends that mirror some of the things that we talked about in State of Care around access and community-based services. So what we intend to do is that the logic of each of these spikes is that colleagues in the intelligence team will analyse the information which comes in, and then they'll provide a report, and that will guide sort of further either engagement work we do or indeed further regulatory work that we might do. So I can certainly, when we get that report, I can certainly bring it back, and perhaps also to the Regulatory Governance Committee, so we can talk about it there. In terms of experts by experience, one of the things that was really important to me is that, and when we let this contract, that it wasn't just about the act of people going on inspections, and there's a part 2 of the contract which is very much about how people who are experts by experience can provide their support and to us outside formal inspections before and after. And if we really want to create an always-on view of quality, we've got to get the voice of people not just at the time of inspections but around that time. So part 2 is gives us that flexibility to test and trial different methods. And I think one thing that I've been really pleased about Choice's response to that is they've worked with us for a number of years, but they suggested some of the things that they might do and might do differently to provide that support. And I'm really happy to bring some of those conversations back to the Regulatory Governance Committee.
Good, thank you. Anything else? So I think, Liz, you provided your own segue into the next item, which is your oral report on last night's RGC.
Yes, so yesterday we had a meeting of the Regulatory Governance Committee. We focused a lot of the meeting on a primary care update, which was really helpful. One of the things that we discussed was some concerning general data that from people using primary care about for some people, lack of feeling involved or not feeling supported enough in management of their own health conditions, but also pressures on the primary care system in terms of workload and vacancy rates and things like that. And we talked about what that meant for CQC. And I think the summary kind of point from the committee was that our ratings must reflect the quality of care for the people using the service. So we don't change the ratings, but at the same time, we are very, very alert and sensitive to the kinds of pressures that exist in primary care, and we want to reflect that in how we frame our reports and our work. We talked about wanting to ensure a strength of user voice in all our work in primary care. We touched on that small number of practices that don't improve or that go in and out of a kind of negative rating, and we just talked about how we can work with partners to try and support improvement in a kind of holistic way. We touched very briefly on digital, and I think that's something we need to come back to, but clearly there's a very important piece of work that needs to be done on informing the public on how to make safe choices about using digital primary care services. We then focused on research and CQC's research and evaluation activity, and so a number of different options about kind of the future and where our research and evaluation activity could go. I think the view of the committee was that it was really important to think about timely evidence. For example, looking at the evidence that already exists, not duplicating, doing evidence reviews and so on, so that that can feed quickly into implementation. And also working in partnership with academic experts in a whole range of different disciplines, so that rather than trying to have all that expertise ourselves, we just draw on the best people for the topic and work with them. In terms of our own research and evaluation activity, we thought some of the areas that could be fruitful would be understanding our own impact and also understanding models of regulation. So, you know, what are the best models of regulation? What can we learn from other sectors, from other countries and so on, so that we're kind of ahead of the curve in terms of our own regulatory practice. But I think not expanding a huge kind of research enterprise ourselves, much more about being smart with existing research and partnerships. I think that was it, unless I've forgotten.
It was a really good discussion last night, so thank you for that. Does anybody who was there want to add anything? Right, it was good. Oh, sorry, Kate. Yep, sorry.
So no, I suppose Peter, my main takeaway from that conversation was we're really interested in using research where we can demonstrate that the outcomes are about improving outcomes for people. So we talked a lot about evaluation and not just evaluating the impact of our independent voice products in terms of people hearing the messages and doing things different, but how does that translate to actual tangible improved outcomes for people using health and care. So I felt that there was a real takeaway that said, yes, let's use what's out there, let's make sure it's informing our rationale and our decision making, but let's keep a constant eye on the relationship between that and improved outcomes for people.
Yeah, I think that's right. Agree. Ted?
Well, I'm afraid I missed that discussion, but it sounds very good. But I just want to emphasise that part of this research needs to be about understanding how our methodology can be as evidence-based as possible. And I don't think we should just assume that empirically, if we go looking for things, we'll find them. I think we sometimes need to understand, and we're talking about getting under the skin of some of these closed environments earlier on, but actually how do we do, what's the evidence behind that? And I think that's a real challenge that we need to build into our research.
John?
In response to that, I think there was you weren't there to hear it, but there was a caution about bowing down at the false god of evidence and just making sure that we had a pragmatic approach to these things and not duplicating what other people's core business is, which is research and development.
We'll leave you to guess where the caution came from, Ted. Anything else? So it was a really good discussion, but both parts of the meeting I thought were excellent. Okay, any other business for the board? Right, so that's the end then of the formal board meeting. I have been notified of 3 people, all of whom are sitting there, who want to ask questions, taking them in the order in which I was given them. Robin, I think you're first, please.
Thank you, Chairman. My question is about the way intelligence is gathered for inspection of primary medical services. And in particular, in the light of the discussion this morning amongst the board members, how feedback from patients is obtained, and in particular, the information about the time that patients have to wait to secure an appointment with their GP, because this is a big concern for many patients. And the current arrangement seems to be, Chairman, that there are some paper forms left in advance of the inspection at reception desk which are widely ignored. And are there any plans for using a more powerful way of engaging with patients, for example, with social media?
Good. Rosie, do you want to start? Malta, you may want to add anything. I don't know. Rosie, start, please.
Thank you very much, Robin, for that question. And absolutely, GP access and people being able to get in to see primary care professionals is a really important area. So just in terms of the data we use, firstly, we use a range of national data sets, which we draw from a range of organisations, including NHS Digital, from Public Health England, from some of the NHS Business Services data that we've got. And also we work with NHS England and NHS Improvement to get data from them as well. That gives us location-specific data for each practice, but it doesn't give us, we don't have any nationally available GP waiting time data in that. We do then look at how we can understand access into a practice in a number of different ways through our monitoring. So we use patient survey data. So every practice has an annual patient survey, and that gives us answers to questions like the percentage of respondents who found it easy to get through on the telephone, the percentage of respondents who were satisfied or fairly satisfied with GP appointment times and the type of appointment offered, and those type of questions. So that gives us quite a lot of information about a practice. We then also use that in conjunction with comments we get from NHS Choices, where people are able to post information about the services they use and give ratings for the services they use. We get information from local stakeholders like commissioning groups, from Local Health Watch, and we also ask on our annual regulatory review phone calls and provider information collection returns that we ask about access and how easy it is for patients to access services. So that's all done in the background, but then when we go in to inspect practice, we have quite a detailed list of key lines of inquiry which actually ask about how practice is responding to people's needs, how patients can access those services. We do look, when we go into a practice, we look very detailed at all of those comment cards, so they're not ignored. Just to reassure you about that, we look at every one of the comment cards that's filled in. We meet with the patient participation group on every inspection to understand their perspectives, and we also discuss with people in the waiting rooms about their perspectives of inspection. So we use a whole variety of information to try and inform that decision and discussion. We are working with NHS England and part of the group that's looking at the GP access review, which is looking at access in more detail. So
I'm not sure, Malta, there's anything to add to that, but if there is, please do.
Just on the specific question around social media. Of course, if through social media concerns are raised and they're being brought to the attention of CQC, then we're already able and have responded to concerns being raised across sectors. We're also actively exploring how we can use social media to monitor more widely where there's spikes in where people use social media to do that, whether it's Twitter, Facebook, or others for that. The reason we're exploring that a lot more than, for example, where we can use material more readily with NHS Choices is that it's, of course, much more unmoderated data. It's quite skewed in terms of where people provide services, and we as the regulator also want to be very open where we start using that data and how. So the reliability and usability of it is somewhat different, but we are exploring how we can do that more regularly through monitoring of social media as well.
Good. So I hope that answers your question. David, you wanted to ask 2 questions, and I'm happy to say if you can be fairly brief, we can deal with both of your questions.
Yes, I have 2 questions. Neither of which meets Sir Robert's stipulations. That is, I do not know the answers to them. Anyway, the first question is that I've been involved in the production of a page for the technology website about the very important thing, simple communication methods for putting faraway families in touch with their people in care homes and people receiving care. I know last I heard of it really was back in November. There was some talk about the actual page being produced about now. So that's my first question, is just where have we got to on that, and when would it be likely to be produced?
So do you want to pause and we'll get an answer to that, and then ask your second question, Chris?
Yeah, so thanks for the question, David. Thanks for your question, David. I share your desire to encourage and promote the use of technology. So this page follows a number of things that we've tried to do. So one of which was to encourage feedback from providers and people who use services about what was working well around the use of technology, and we've published a report which sort of highlights 10 examples of how technology is being used to improve the way people receive health and care services. I know this particular is a more general bit about how people can stay in touch. So there's a draft of it that I've seen that we'll have ready to go on the site by the end of this month, so effectively in the next couple of weeks. But I also, like him, want to try and get more feedback from people using those services so that they can be the information that we're sending has real meaning. So I hope that page, as it goes up, will encourage other people who use services, other organisations that, as he knows, we've written to give us their experience of using that technology to help improve people's linkage to their families, and we talked about the idea of how technology can support people who might otherwise be lonely. So that page will go up on the 29th. I'll make sure that you can see it before it goes, so we can agree that it's okay. But I want it to be part of a story about how technology drives improvement in the way people experience health and care services.
Yes, I would hope that something would come out very soon, partly because that would stimulate people to give their experiences, which they might otherwise not do. My second question is about a report that you published in October called Identifying and Responding to Closed Cultures. I suppose that it was inspired by the Walton experience. And I'd like to commend you on that report. It was very interesting reading. I think in some ways very novel reading coming from the CQC. And I'd also like to commend you on the signs of a much rather tougher approach to inspection that is developing. I've noticed this, particularly there was an article in one of the professional papers for care, which from a solicitor's firm, which was saying how much tougher the CQC was getting, and people should use their services as a result, people in care. So, but the thing about this report was that it was how to spot warning signs of a closed culture. And that isn't the same thing as evidence, and evidence
is fairly important, though it may be a false start. This puts you, I think, in, well, my feeling is this puts you in a difficult position, because on the one hand, once you've seen a warning sign, you have a sort of moral duty to tell the public and the care users about it. On the other hand, if you do that and you then give an inadequate rating, you're likely to have a legal challenge to it because you haven't actually got the evidence. And I wonder, therefore, if something like perhaps, Kate, your program board that you're doing at the moment would look again at this question of how you would actually get the kind of incontrovertible evidence which would stop people bringing legal actions against you, and also bring these closed cultures and this abuse to an end.
Do you want to have a go at answering that?
Well, thank you for your comments and challenge, David. I actually think we need to do both. I don't think it's either or. We need to identify circumstances, care where there is an environment or a culture that puts people at risk of abuse, and we need to act on that. We don't want to wait until, we don't want to sit back and say we haven't got evidence, we can't act. We need to act on the risk of abuse. And I think we have it within our powers to do that, and I think we need to be bolder on acting on that, because I mean, our job is to protect people from abuse, not to wait till it happens and then intervene. So I think you're right to say we need to look for signs of evidence that proves abuse is taking place, and we need to improve on that. And there is work going on in the work streams that we talked about earlier on to look at how can we evidence abuse. But I don't think we should step back from looking at the risk factors for abuse and acting on that as well. I think we've got to use the full panoply of the evidence in front of us, and we've got to be able to act on all of it. If people are at risk of abuse, we need to intervene. But equally, we need to look really vigilantly for evidence of abuse going on.
It's quite a complicated situation, I think, and it's a theme we will be returning to, I think, when Professor Murphy report comes. I think that would be another opportunity for the board to probably discuss some of that. So thank you for your question, David. And Andrew, the last question goes to you this morning.
Mr. Wyman, thank you. My name is Andrew Ward. I have a background in public protection. Last week, I listened to the NHS Chief People Officer, Prena Issar, at an event. And Prena clearly advocates for freedom to speak up, and as she said, and these are her words, as part of a solution. Afterwards, I met Prena, and she kindly replied with what I thought was an interesting and indeed an honest response to my question. As Chief People Officer, Prena, who do you work for? And I should add, it was the first time I'd met Prena, and she had no advance notification of my question, unlike yourselves. I think it would be helpful for patients and families, those you regulate, their staff, and indeed your staff, for the CQC to step back, consider my question, who does the CQC work for, and respond as Prena did in a few sentences. Thank you.
So I don't think we need to step back and consider it. I think if you ask any person who works for CQC, they would unequivocally say, we are here for the people who use services. They are the people we work for. So that's the absolute clarity as to our approach. It's if you look at the 2008 Health and Social Care Act, which is the act that set us up, it is quite clear that our legal that is our role, and our accountability for that is to the Secretary of State for Health and also to Parliament in practice through to the Health Select Committee, so Health and Social Care Select Committee as it now is. So I think we're all absolutely clear who we work for. Go on then.
So previously you've said it's not your policy to avoid answering difficult questions, and then a few months later in February 2018 you wrote to me, and he's not here today, and you said, other than your question to Sir Robert, which in any event I would have said that could not be asked in a board meeting. So Sir Robert's not here, but could I please ask that I have a response to that question, because I've never had a response 2 years later, and it's highly relevant. We've talked about freedom to speak up, or you have today said how important it is, talked about whistleblowing, how important it is, and yet some trusts still appear to ignore Sir Robert's recommendations in their treatment of whistleblowers. And I would contend that nothing has changed despite freedom to speak up.
So you may have to be kind and send me the question again, because I have no idea what your question was off the top of my head. But just not, you hear when Henrietta was presenting, you heard what some of my colleagues said. We are passionate believers in the important role that freedom to speak up and the benefits that flow from people feeling able to speak up is really, really important. So I'm not sure what I can add, and I'm not sure what your question was, but if you send it to me again, we'll deal with it. Thank you, Robin, and thank you everybody else very much indeed for coming this morning. Board, I think we need to resume in 45 minutes' time, if that's okay. Thank you.